Good morning and good afternoon to all our friends out there. My name is Kay, and I warmly welcome you to another live interview of the On Foundation. Today, we have another wonderful guest from the United States. With me here in the home office studio is Dr. Jason Hammond from Baltimore. He's orthopedic surgeon at the MedStar Union Memorial Hospital, where he's specialized in sports medicine. And he focuses on shoulder and knee, all types of conditions. And he treats meniscus, cartilage, ligaments, all a patient can need. And he uses classical approaches, but also regenerative medicine, cell-based. And if nothing else helps anymore, he also puts prosthesis. So he's a real specialist. He's published many articles and books, and today we're talking about one of these books. And he's also taking care of different professional and college teams. But his absolute passion, besides his wonderful family, are his patients. Today we're talking about patient and doctor relationship. So I warmly welcome Dr. Jason Hammond. And I'm happy to start that interview soon.
Thank you very much, Guy.
Thank you. Thank you. Great having you here. Before we start, I'd like to motivate the crowd out there. Maybe if you're there already, send us a message in the chat. Tell us who you are, from where you are, and maybe whether you're a doctor or a patient. That might be interesting. And whenever you've got questions of any kind, please write it down and we will ask you and discuss. Okay, so Jason, let's start. Actually, let's start maybe with you. I'm always curious what actually made you become an orthopedic surgeon.
You're interesting. I have always kind of known I wanted to be a physician. Ever since I was in 4th grade at 9 years old, I used to collect stickers. We had a sticker book, and it was all kinds of stickers, and it was a lot of fun. One of the stickers that I picked out, though, was what my name meant. And interestingly enough, Jason means one who heals. And I was like, oh, that's awesome. That is great. That's what I want to do. I want to heal people. And my mom was a nurse who was a professor at a college. And so I got a chance to go to her work sometimes. And there was a skeleton that was hanging down. And it was fun as a kid going in there because I could just push the skeleton and see the bones wiggle and jiggle. And so I always was very interested in that field. And I tended to gravitate more in biology, more so than some of the other social sciences and more math and that type of thing. When I was in high school, I was in a track and field team, and I was a high jumper. And one time we were in an indoor track meet, which is in the winter time, we have it indoors, and it was inside of a gym. And I went to high jump, and I went over to clear the bar, and my back and head landed on the mat, but I was too far over. And when I landed, my foot came down and hit hard on the ground, on the wood floor. So when I was seen by the athletic trainer and the coach, they put me in this cold foot bath, which was, I could feel it in my bones. It was freezing. That was a horrible experience there. But it turned out that I had a break in one of my bones. So I went to see an orthopedic surgeon. That was my first, interaction with a orthopedic surgeon. I was placed into a cast. Fortunately, I was in a cast for 3 weeks, but you don't realize how important your limbs are unless you don't have access to them. And so I really didn't like being in a cast. But one of the good things about being in a cast was I got a lot of love from the ladies. They would want to open the door for me. They would hold my book bag. And so that was nice until about 2-3 weeks later when the cast started to smell, and then they were gone. But that was really my first interaction. And after that, I really liked the aspect of treating bones, treating people who are relatively healthy and getting them back quickly and seeing quick results.
Nice. What motivates you in your career?
Yeah,
No.
so I've got a lot of various motivations, self motivations, family motivations, motivations to help people, seeing people happy, seeing their lives changed. I think that is one of the biggest motivations for me. I want to be able to just see somebody who comes in limping significantly, who can't sleep, who's not able to spend time with their loved ones or their family, who every waking moment they may be thinking about their knee, specifically with arthritis, and they have to turn down vacations, they have to turn down time with loved ones, and to be able to, if I were to do a procedure, whether it's regenerative medicine or other conservative measures or knee replacement, and be able to turn their life around, that is truly motivating and sort of addicting. Actually, it's really nice to be able to see someone be able to get back to doing the things they love. One of the things I told one of my patients today is that I'm not treating your knee, I'm treating you. And the goal is to help your knee so that you can do the things that you love.
I think that's an important aspect, and an aspect that you also covered in your amazing talk at ONstage last year. You talked about breaking the language barrier, and it was about the relationship patient and physician. Want to tell us a little bit more about you as a patient, you as a physician, your thoughts behind?
Yeah, so it is an interesting dynamic between someone who is in authority versus someone who is more vulnerable. And that dynamic is all throughout society, whether it's a professor and a student, whether it's, physician, patient, parent, and daughter or son. And when you're in that situation as the authority, you have to be keenly aware that you are controlling everything about the situation. You're controlling the dynamics of what happens in the interaction. You're controlling the staging. You're controlling the where you are located. You have complete control over a lot of the situation, and that is, and you don't really understand what that may mean to somebody in a more vulnerable situation unless you were to really put yourself in that person's shoes. And so one of the things that really helps is first recognizing that you have that authority, recognizing that you are in in a lead role, and then making the other person feel as comfortable as possible in that position. And I think that in order for that to happen, depending on the interactions, you've got to be able to humble yourself and really, kind of put yourself on that person's level, especially if you want to have an open communication, an honest communication, where the person who's in a more vulnerable situation feels comfortable expressing themselves and letting them know what it is that they actually need or want. Now, obviously, depending on the interaction, whether it's in a police and an assailant, whether it's a professor and a student or whatever, there are different ways that you want to take that. But from a physician-patient interaction, patients really don't want to be there. They don't want to be hurt. They don't want to be in a position of vulnerability. They don't want to have to strip down and expose a body part that they really don't want. They don't like somebody to kind of examine them and touch them in ways that they're not comfortable with. And that makes people extremely uncomfortable, especially if you start talking about injections and other things. So that, one of the reasons why I did this talk is just to try to just expose that aspect and help other surgeons and physicians alike to keep that in mind.
Are all patients the same in their fear, or does it depend on the type of injury?
Yeah.
Or treatment?
Yeah, patients are definitely different. There are patients who are more educated about their injury or their problem, and there are patients who have no idea what is going on. I do think that patients who don't have any idea what's going on tend to set a narrative in their head about the unknown, and they may have more fear going in than potentially somebody who knows what's happening, has a good idea, maybe who has had multiple second opinions and coming in for informational purposes only, or for you to do their procedure for them. And so, taking that into consideration is really key. And so for the patients who definitely who are more fearful and who really don't know what's going on, a lot of their fears are irrational. There's the unknown of the unknowns, and they, may not realize that, that the likelihood of something truly bad happening is very low, or the likelihood of needing surgery is very low. People always, a lot of times, think of the worst. And so, what I like to do is, kind of get myself on their level, maybe introduce myself, not necessarily by doctor, by my name, as if I was in a barbecue or something where you're talking to somebody. When I'm at a barbecue or a night out or a dance or something like that, I don't go around calling myself Dr. Hammond, because that would make the interaction weird. So, but when I'm in the office, it depends on the situation whether I'll do that or not. I may or may not wear a white coat to try to get things to, de-escalate. I'll likely sit down instead of standing up. Those are just little things that can be helpful. And then speaking in common sense, everyday layperson words is really something that a lot of physicians, unfortunately, don't do. And so that increases the anxiety for folks. Not only that they're fearful and unknown, but if they don't understand what you're saying, that just increases their fear, and it makes them more uncomfortable asking questions because they feel a little belittled, and they feel like they should know more than they do actually.
Okay, that's already very good advice.
Yeah.
Before we dig deeper into it, I'd like to say hi to some people. We've got guests now from Greek, Thessaloniki. You know him. It's one of your co-speakers, Emmanuel.
Yeah. Hello. Good to see you.
We've got a guest from Cyprus and two wonderful ladies from Zurich and Lucerne.
Oh, fantastic. So all over the place. That's awesome.
Yeah. Okay, to come back to the patient-physician interaction.
Yes.
You explained how you take their fear. I think that's also already very, very helpful. Mm-hmm. But you also mentioned that patients have less fear who are already well educated. How do these patients get educated these days?
Well, so there's good ways and there's bad ways. There's some people actually who feel that they are getting good information, but may not be getting good information. In my talk, I talked about one of the most famous doctors and who gives a lot of information, and that's Dr. Google. And being internet savvy and looking at the internet and looking at different things about what you perceive may be your condition is a good thing. And you want to be able to have all the information at your disposal. But the problem is taking that information as gospel and looking at, because we're usually just like in social media, just like in the news, usually what gets a lot of hits and a lot of views are the extremes, are the things that are either rare or something that is shocking. And so a lot of times what you're reading are what is already getting a lot of views, what's moving up higher on for SEO optimization in Google, what moves up higher are the things that are read the most, right? And so something that could be read the most could be something that's extremely informational, but it could also be something that's extremely shocking that is or just completely out there. So you got to be careful about what you're reading, especially on the first page of Google that's gotten a lot of hits, because if it is something that's extremely unusual, extremely shocking, or there's a problem, or there's an unusual complication for a total knee surgery, and now you're scared to get knee replacement because you've heard of somebody having this horrible complication because it was on the first page of Google. Well, you got to kind of think about that and read and wonder, okay, I need to slow down. Let me not get too scared. Let me get some good information from a real source. So, but I do think that the internet is really good. I get a lot of information from the internet on a lot of different things that I'm not very familiar with also. But I think that, taking that, getting good doctor's advice can be helpful. And nowadays, since COVID has happened, it can be easier to reach a physician because a lot of physicians are doing Zoom or doing telehealth or doing video conferences. And so even if you're not able to get in to see a doctor, you can still use the same laptop that you would go on Google for and look at and talk to somebody and get some really good information. So that is a good place to go. You can go to there are some good sites that are credible through various associations, whether it's the American Medical Association or the American Association for Orthopedic Surgeons or things like that. They will obviously give you good, credible information as well. So if you can go through a good source like a society or even WebMD, things like that, places like that will give you good information also.
Is there any information you give to the patient except your advice when he sees you or when he calls you?
Yeah, so we definitely, there's a couple of things that we need to talk with patients about. We want to talk about what is their diagnosis first and what does that mean for them, not necessarily for the problem of their individual joint, but what does that mean as far as their activity level and what does it mean from their social interactions and all that stuff. So if they're gonna miss out on a baseball season, or if they're gonna miss out on playing golf for the season, or if they're gonna have to rearrange their vacation plans or things like that, they need to know about it. If they're not gonna be able to play football ever again, then that's something that we need to kind of go through. So it isn't just information about the diagnosis. It's a lot of the time that I spend is what does this mean for you individually? Because each diagnosis means something different for each person. Now, obviously, that does entail treatment plans as well, and whether it's conservative treatment and all the options therein, or surgical. But usually it goes back to what is the best treatment option for this particular patient to help them achieve what they want to achieve.
Mm-hmm. You, as I said before in the introduction, you perform all types of surgeries, like classical repair surgeries, replacement, and also regenerative approaches.
Yeah.
Is there a field where patients have a special lack of information or need of information?
Well, yeah. So, the newest procedures are the ones that even the most educated are still undereducated about. And the newest procedure that we're doing in orthopedics is regenerative medicine. It's even difficult for physicians to get a grasp, even orthopedic surgeons to get a grasp on that. So, I definitely don't expect patients to go in knowing all there is to know about regenerative medicine, what it can do for you, what it cannot do for you. And there's a lot that is unknown even for us about that. So we will definitely want to be able to educate them on these newer procedures. But yeah, so when the person who comes in who's fairly educated about their problem, they may have had a couple of other opinions, and they really know what they want. They may not know about regenerative medicine as even an option, and so I will bring that up to them, and then that kind of resets things, and they have to kind of think about that as a possibility. So it's up to the physician to be as up to date as possible about a lot of the different things, because we are creatures of habit, and we kind of know what works in our hands, and we know from the years of experience. So we usually do the same things that have worked over and over. But being able to keep up with what's new is going to help move things forward, and also be the best for our patients.
The new technologies, regenerative medicine, is partly pretty complicated. How do you explain that to the patient?
Yeah, so it's been very difficult, and that's really one of the reasons why I wrote that book about stem cells for joint pain. There's a lot of misconceptions about it, and there's a lot of big words, and there's only so much you can kind of comb it down to make it really understandable. And so typically, I want the main thing that I have people know is that, okay, I don't expect that when we inject these cells, that it's going to regenerate your knee to back how it was when you were 18 years old or 19 years old. That's something that they need to realize. They need to kind of understand what the role of decreasing inflammation is and how that is important. They need to understand what these are and what these are not. And a lot of, as you know, the term stem cell is not exactly what we are injecting for a lot of joint pain problems. But patients don't know that because they've been on Dr. Google, and stem cells get hits, and stem cell regeneration gets a lot of views. So when they look that up, that's what they see. So when they come in, we've got to kind of retrain them and just kind of re-educate them about what it is and what it is not. And the varying different types of cellular products that we use, whether it's fat, whether it's bone marrow, amniotic fluid, placenta, things like that. And so, that is the main thing. And so for a lot of my patients, we have to, I usually do this procedure, these regenerative procedures for arthritis. And so by the time they get to the point where they want to do a regenerative procedure, then it's really a matter of they've tried a lot of other things. These aren't covered by insurance in our office, really in the US right now. And so it's very expensive. It's very new, but knee replacements have been around for over 40 years, and they're tried and true and have a very good success rate. And so it's very patient dependent on where we go next and what they would like to do.
That's a good example. That's a replacement. Are there patients who ask for a replacement, or would they always prefer regeneration?
So it goes back to what is it going to take for that person to get back to the things they love to do, and what is it going to take for them to not have to come back to see me, basically, bottom line. And also it depends on whether it's covered by insurance or not, because that's unfortunately that's a real issue here. And so there are patients who come in and say, I'm ready to get a knee replaced. I'm going to get my knee replaced. And that's, they've already gone through, multiple different conservative treatment options, which include activity modification, rest, bracing, physical therapy, injections, anti-inflammatory medicines. They've kind of gone through all that, and they're tired of the, running on the same wheel, going over and over, doing the same things over and over again, and they just want to get it taken care of. And so it is, because that wears in your mind. A lot of this is mental. And so, because if you're thinking about your knee every second of the day, all the time, that wears on you. You got to using that mental energy when you're trying to do other things, and you have the emotional energy spent of being in pain and not being able to spend time with your family. And so when we talk about regenerative medicine, I have a lot of patients who get that, who get back to doing the things they want to do, and they are excited about it, and they're happy about doing those things. But I also have patients who, it hasn't really worked like they wanted to, and they go to knee replacement, or we just go back to other therapies. But there are people who want to have a knee replacement. There are people who are just focused on just getting regenerative medicine, and there are people who just say, I don't want any of that. I just want to keep getting my cortisone injections or bracing or whatever. Okay.
Before you mentioned your book, and I think many people, they don't know the book, so we should talk a little bit more about it. But first, sure. I'd like to show it. You see, it's a pretty unusual book, the good book on stem cells for joint pain.
Yes.
It's not only the cover which is different; it's also inside. It's pretty different. So it's pretty unusual. So do you want to tell us how you got the idea of such a book?
Yeah, so I knew that it was difficult to try to break down what regenerative medicine is all about, and I was trying to figure out a way to really explain it to my patients. And it turned out that my wife had come up with a sort of a comic book idea, talking about fertility treatment and trying to make complicated things simple, and trying to make things that are difficult to talk about something that is more approachable, or something that somebody would be able to really be able to digest. And at least in the United States, fertility treatment has varying connotations for different people. It can create different emotions for various folks. So she came up with the idea of creating a comic book style approach to education, with talking about fertility treatment. And so she wrote a book called The Good Book on Good Book on Infertility. And so I kind of took that and ran with it. I was like, this is a great idea. Stem cells are very, people don't understand what they are not. The terminology is all over the place. So that's really the main way where I came up with the idea. And then I just had fun writing it. It was nice. It was nice to be able to try to create something new, and just have fun with it. I tried to make it light, and I tried to have some things in there that makes it entertaining. It's hard to make. Sometimes it's hard to make a health book or a book about medicine entertaining. So that was really a goal of mine. So it was just a good time.
A wonderful book. I love it.
Thank you.
What is the feedback of your patients?
Yeah, so they have, most of my patients who I've given this to the patients who have had the procedure just as a gift, and I've had other people read it. They love the way that it flows, and they like just the information and how it's presented. And so a lot of them really understand what this is all about. Some people have said from reading that, yeah, I want to proceed. And some people have said, no, I think I'll go a different route. And my goal is for them to really be able to make an educated decision and understand why they're making the decision and what are all the alternatives. And but yes, it's been really good feedback.
Yeah, great. So maybe, as we have a few of these books, fortunately as a gift from Jason in our office, I'd like to offer 3 books for free to the first 3 who write in the comments that they want the book and maybe why they want it.
Excellent. That'd be awesome. Thank you. Yes.
So thank you. Mm-hmm. Let's touch on another difficult topic. Okay. Before, you said that COVID-19 actually has an impact on the patient-doctor relationship as well.
Yeah.
You mentioned a good example, but are there also the negative sides?
Yeah, and so I think that one of the things with COVID-19 is that there's been social isolation. A lot of my patients, who especially are elderly, have not been able to get out of the house because things have been on lockdown. Not only have things been on lockdown, but there's a significant fear for anybody who is over the age of 60 because their risks do increase with this. And so they have had the fear, they've had the government saying that you shouldn't go anywhere, and they are also isolated from the family because the family doesn't want to inadvertently get them ill or sick, because that you can be asymptomatic and then transmit the disease, and that's been shown. So I've had a couple of patients who are in their 70s who came to see me recently as we started opening up, and they said that this was in June. They haven't been out of the house since March, literally. One lady said that she went out only to see her pulmonologist for another issue, and that was only a couple of weeks ago. And so they came to see me because their knee pain was just so bad, they just needed to get their cortisone injection. But they have been isolated from their family. They have, one of the ladies was widowed, so she's really by herself. And a lot of these patients don't have a good network of friends because their friends are either elderly, they can't get out, or they may have passed on as well. And so that's been very difficult. And so the terminology of social distancing, I think, has led to people thinking that they not only need to distance, but they need to socially isolate as well. And I believe that the terminology of physical distancing is better, just from an emotional standpoint, because you can physically distance. You can wear a mask, you can be 6 feet apart or more, and still have some social interaction. And I think that can be really helpful for the mental health aspect. So a lot of my patients, I'm talking to them about that and trying to get out. At least, if they're out, they're going to treat themselves to the drive-through, go to Burger King or McDonald's or something, just get out, just because a lot of these people have been getting their food delivered to their house and for months, and not, so that's really difficult. Part of the other issue is wearing a mask. We have to wear a mask right now with all of my patient interactions. And there's so much that I can tell from facial expressions and being able to see a person's face when I'm telling them something difficult, or when I'm joking with them, or when they're telling me something difficult, or just in general, if I'm examining them and I'm pushing on a part of their knee, I usually can tell if it's painful or not, but because they grimace, and that's hard to tell sometimes. And so use all those cues, and all of that's gone. You can just see you're just seeing eyes now. And so, when that is removed, that little bit of interaction, and you can't see their mouth anymore, or you can see their eyes, you got to be more in tune that, yes, I am in a position of authority. They're in a position of vulnerability. They can't see me smile if I'm joking. They can't tell if I'm serious or what's going on. It makes it even a little bit more anxiety provoking. And it's the same with from their standpoint. I want to know if they're being emotional. I want to know if they're grimacing. I want to know if they're smiling. And that's a little bit more. That's a little bit more difficult nowadays.
And how do you deal with it?
Yeah. So I think it is the masks. They're there. They've got to at least right now we're wearing masks. I'm hoping in the near future, maybe if we can sit at other parts of the room and we can be far enough apart, maybe we can slip down the mask and talk. I know that is happening at restaurants here where we're sitting down and we're eating, but we don't have a mask on, and the waitress comes on with her mask, but we can at least talk with her. So that may be coming, which will be huge. It'll be really nice. But in the meantime, it is really, taking your humility to another level, being able to see patients, face to face, looking at their eyes, being really in tune with what they're saying, and really, be as empathetic as possible. And for the getting patients in, just in general, having them come in to get their injections, to get their medical treatment. Another issue besides COVID and the economic crisis and the depression and everything else that's happening is people have not been coming to the doctor because they've been afraid to get COVID. They've been afraid to be in situations where they might get exposed to that, but they haven't been getting their cancer screenings. They haven't been getting other treatment that can really prevent further disease. So I think part of the process of dealing with this is just getting people in to see physicians so that we can have these conversations.
Hmm. You mentioned before telemedicine, which has come up. Do you think it came to stay, or will it change back to normal?
Yeah, I think that there is a role, and I think that a lot of physicians are seeing the role. I have talked to a lot of physicians who say that there's nothing like actually being able to talk one-on-one in person, nothing like being able to physically examine a patient. And those are all things that are you can't, there's no substitute for that, for sure. But from an educational standpoint, an educational role, if we can talk to patients and educate them about a diagnosis, this is a perfect way to do that. It is great to be able to, if we, like right now, we are across the world from each other. But if there's a patient who wanted to see me, who may have heard about me through either my social media or through another physician or wherever, and they aren't able to physically come to see me, then this is a great way to talk with them about things and assess if they're not able to commute to come and see me. So I think there's a role. I think this is going to be really good for second opinions. I think this is going to be really good for education. I think it can be really good for post-operative treatments. If they don't need to come in and see the doc, just to, they can show me their incision online. And if it looks good and I don't have any other worries, otherwise there's no need for them to hobble back in here when they're already on crutches and stuff. So I think there's a role, and I think it's going to stay. And there are patients who just aren't able to physically get in, or if they're on vacation, they got hurt and they want to talk to me, and they're still in Switzerland or wherever, and then they can find me that way also. So there's a role for it.
Good. Yeah. Do you think the attitude of patients towards physicians and scientists has changed during the pandemic?
Yeah. So the attitude of I think that people are more vulnerable, and they kind of may feel a little bit more of that vulnerability now that they can get ill. That this has become real. That viruses and infections and illness can come close to home. It's not just way out there, somebody else's problem, and so that is something that has changed the mindset. I think that how we interact with patients is definitely is changing, because the role of a physician is to do no harm, and a lot of doctors and a lot of people go to work with a cold. That's before this. People would come to work. I got a cold, but I'm just gonna push through it. I'm not gonna take time off of work, and you come in with your cold and you're sneezing and everything else. And before, people was like, "Oh yes, you're a great worker. You come in, you really care about the company." Now it may not be anything that people want to deal with, and I think that is a good thing overall. I think that there's less of a stigma of wearing masks. Before this, if you wore a mask, people would think, "What's wrong with you? I don't have a disease," or you think, you're offending me for wearing a mask around me, like I'm going to give you something. Now, I think that mindset has changed, and that's a good thing as well. I think that more people are cognizant about washing hands. I think, I've been in many locker rooms with my athletes, and they would universally go to the bathroom and will come out without washing their hands, or just doing things and not washing their hands. I think that it is kind of, that trend is changing, where it can be kind of cool. It's cool to wash your hands, to keep yourself clean. You're not going to, infect somebody else. So I think in general, it's a good thing, and it's going to change things for the better from an infection control standpoint.
So there's a good side. Great.
Yeah.
So let's hope that the pandemic is history soon.
Yes.
I think the numbers also in the States look promising. You told me that in Baltimore, it's actually looking pretty good now.
Yeah, exactly. So Maryland, it is going down. It's at the positivity rate. Maryland is down. It's around 5%, which is its lowest since, they said, March 29th. So it's going down. And that's a good thing. There are some states that is going up though. And there's about 15 states, between Florida, Texas, Arizona, as the economy is starting to rebound and people are going out, it is increasing some infection rates. So, and there are hot spots here and there, but, I don't think that people are going to go back to the social isolation anymore. I think that, a lot of governors are saying, there's kind of an acceptable risk that they're going to have to take. They're going to keep the economy going now, and it's just a matter of wearing masks, social distancing, and being just being as safe as possible. So there's going to be a balance, and we're going to have to learn to kind of live with that and for the foreseeable future until we can get herd immunity and or a vaccine.
Yeah, I'm optimistic that we get it under control. So
Yes.
I would like to look a little further in future and maybe talk the last 2 minutes or so about regenerative orthopedics.
Yes.
Where do you see the future? Do you see trends,
Yeah.
breakthroughs?
Well, I think that the future is definitely research. I think that the holy grail, from the time that we as orthopedic surgeons have started to do knee replacements, back in the 70s, the holy grail has been to be able to stop the process of arthritis or just degeneration and recreate cartilage. And that has been elusive for many, 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 many years. And regenerative medicine has given us a glimpse of hope that we can do this. We can get close. We've seen it in vitro. We've seen cartilage regenerate, and it is definitely going to spark interest of researchers and scientists for years to come. It is also it's going to be the person who, or the group that figures this out there's a huge economic pressure to figure this out as well, because you can imagine that if a group can really turn the clock and kind of reverse time and get rid of arthritis or get rid of degenerative problems, then that company is going to do very well. And so this isn't going anywhere, from those two pressures, research and from the economic side. I think from the physician's side, a lot of physicians in this area have been very cautious to jump on new things. And I was one of the first in my group, and honestly in Maryland, to start doing regenerative medicine procedures. And I've seen very good outcomes from the patient standpoint. People have been able to really get back and do the things they want to do. It's really helped decrease inflammation and pain. So I'm excited about the future. I think this is a game changer. I think that we're still in the infancy. I think we still got a long ways to go, obviously, but it's here to stay for sure.
You mentioned research is the key. The On Foundation, we also offer research grants. On which important open research question should we speak the next grant?
So the important research question, yes, or is that what you asked? You said what's the next important research question? Yes. Yeah, I think that. I think what is. Yes. So what I usually use is I use fat from autologous fat for my regenerative medicine, but I think bone marrow and other forms are very good. I do think that how much fat is necessary, it would be really helpful, and I think that there are studies that are coming out that are going to look at that. But what is the desired amount? Is there is there a particular method of isolating the specific fat cells? Because right now there are some that spin down. There are some that are filtered, that filters the fat. So, and who knows how much fat to inject? And I usually do mostly knees. So I want to know, is there a certain amount of fat that I can inject that will give me the same result and less pain? Because if I inject 18 cc's of fluid and I only need to inject 3, well, that's a big difference from the comfort level of the patient, because injecting all that fat in the knee is uncomfortable for sure. And a lot of the injections are for like amniotic preparations are just a very small amount. I kind of think that more may be better, but that's not always the case for sure. So we can figure that out. I think that would be something that would be extremely helpful. And which preparation would be the best, whether it's fat, whether it's bone marrow, placenta, or something completely different.
Yeah. Thanks a lot for sharing these thoughts. That's very helpful to us.
Yeah, no problem.
I think, unfortunately, time was rushing. We have already come to the end of our interview. Okay. So maybe a last chance to ask a question from the audience. Very last one. I think they all leaned back and enjoyed listening to you.
Well, I appreciate it. Hopefully I didn't put anybody to sleep.
No.
Okay.
Okay, I see there's no burning question. So I'd like to thank you so much, Jason.
Yes.
It was wonderful talking to you again.
Yes.
And I hope to see you soon on
Yeah,
screen and live, hopefully.
Yes, you as well, Kai. I really appreciate this opportunity. I think what the On Foundation and what you're doing as the executive director is absolutely amazing. Very important work. So I congratulate you and everybody associated with the foundation. And for Paula, who's behind the stage, you're doing a great job as well. So I appreciate you.
Very kind of you. Thank you so much.
Thank you.
Have a wonderful day.
No, you too. Bye-bye.